Welcome back to the Philadelphia College of Osteopathic Medicine, Georgia Campus School of Pharmacy, ASHP-SSHP Clinical Skills Competition Case Number 4, the ASHP 2013 Local Case for DVT and PE, categorized as a cardiovascular problem, and one of the top contenders in recent years for the case types. Like always, for those joining us today, my name is Michael Cooley at the PCOM Georgia ASHP-SSHP Student Chapter President for the academic year of 2017-2018. I know I say it every time, but I still got to. Like always, my view doesn't reflect in any way the views of the faculty, staff, the school, and of ASHP. The school has no financial ties or disclosures. This information is not sponsored by ASHP. And for completeness' sake, this information is to never be used as medical advice or substitute for a medical professional. If you are having a life-threatening emergency, please call 911 or go to your nearest emergency room. I hope these sessions have helped you improve your methods and your consistency. And if you have any tips that you would like to share, please do. I'm always interested in how other students and chapters work on their SOAP notes or their Pharmacist Care Plans in this case. These are your printed references that can be found in your student handbook of your current academic year and will also be provided to you at the national competition. However, from a student perspective, I have had the most success with the pharmacotherapy reference in my cases. Which one does your team prefer, or your institution prefer? I'd be very interested in knowing. Let's take a look at the acronyms. Which acronyms do you guys use? In my cases, I use for the subjective All Smash FM with Fed tacos listed, but I always say Def tacos, as in we're definitely getting tacos in our social history tonight. For our objective, we have our vape, and for our plan, we have Mr. T. Alright, on to the bigger sections. Let's take a look at the subjective. For the allergies, it's not really an allergy, but it's an intolerance of warfarin leading to nausea. For the past medical history, we have a DVT 8 years ago, treated with warfarin for 6 months, and seasonal rhinitis. The history of present illness is the patient presents again with a DVT. This patient got the DVT because she wanted to be back on her birth control and didn't tell the provider. Now we see NSAID duplications, binge drinking. Looking in particular at the social history because of its important role in the development of the DVT. We'll see her tobacco use at 1.5 packs per day for 10 years and still a current smoker. We'll see her alcohol use at 5 to 6 drinks a night on the weekend, resulting in increased use of her NSAID or blowfish. Her occupation is a sales manager that travels regionally. This is important because you'll see decreased ambulation or the ability to move due to car rides or plane trips, and she has unknown sexual relations. Now looking at the objective, or VAPE, the vitals, physical exam, and labs, we see in her vitals that she has slight tachycardia and slight tachypnea. For her physical exam, there's a minor detail that might have been missed by students, and it's the mildly inflared nares, indicating that there is still presence of the rhinitis. This is something that is very minute and a lot of students may miss, but it's also indicative that the disease is still present in this time. Looking at our labs, we notice that the D-dimer is elevated. Normal D-dimers are around 0.5 microgram per ml or 500 nanogram per ml. But with this patient at 4,300, it refers back to the DVT. Alright, let's review the assessment or the prioritized list. Our number 1 or our most urgent problem is the recurrent DVT. Our number 2 are things that must be addressed during this visit, and these shouldn't come as a surprise as each one of these led to the primary problem or the DVT. And that would be our binge drinking, our overuse of aspirin and NSAIDs, our smoking, and our birth control concomitantly. Number 3 is our follow-up, and that is going to be our rhinitis. Okay, let's go ahead and take a look at the plan. Remember that in every section of the plan, Mr. T must be included, and that's going to be your monitoring and therapeutic endpoints, your recommendations of therapy, and your therapeutic goals. I want to review a concept next, and this is mainly for the students that haven't had the appropriate therapeutics class first. And it really looks at DVT or deep vein thrombosis and PE or pulmonary embolism. These are sort of venous thromboembolisms, and each one of these should be considered a medical emergency. And the question is, why not? Why do I not require thrombolytics to save the tissue? So, when you look at the literature, you have to see, does the VTE or the venous thromboembolism, when the patient presented with it, does the patient have cardiopulmonary compromise? Or if it's a DVT, do they have a high % chance of losing a limb? If they do present with one of these options, then thrombolytics would be necessary. However, because this patient is an outpatient and only has trouble breathing, only anticoagulation is warranted. Now, this concludes today's session. Thank you all so much for listening. Please leave your comments and concerns down below, and have a good day.